morning we've been hearing of interesting things, and like Dr. Sharda Jain said, that you have to figure out what is your area of interest and follow that. Now what I'm going to talk about is something which is inevitable. We'll be seeing it in all our female patients. Extremely common because aging is going to happen, and with that we are going to see GSM. GSM being the genitourinary syndrome of menopause. And what I'm going to be talking about is the G, that is the genitourinary, so the genital part of the genitourinary syndrome of menopause. Of course, all of us know about estrogen creams and all, but probably I'm going to be talking a little more of something which is coming up and what are the new things that are there in the armamentarium. So vulvovaginal atrophy is a frequently neglected symptom of menopause even today. While an estimated 40% of women are affected by the progressive symptoms of vaginal dryness, irritation, itching, dysuria, and dyspareunia, only a quarter of symptomatic women are believed to seek medical attention. Until recently, treatments for vulvovaginal atrophy were limited to often insufficient or inappropriate local estrogen therapies and over-the-counter lubricants and moisturizers. So this is basically the silent symptom of menopause, and it has a large impact on the quality of life and sexual function. Unlike vasomotor symptoms of menopause, which typically abate over time, vulvovaginal symptoms are usually progressive and less likely to resolve without effective treatment. So what happens in the vulva, vagina, and the genital area is what I'm going to be talking about. As the estrogen levels decrease, the vulvovaginal tissues become progressively avascular, collagen fibers fuse and hyalinize, elastic fibers undergo fragmentation, and connective tissue increases. The vaginal epithelium becomes thin and pale, shows loss of rugae, which may result in signs of inflammation such as erythematous patches with fine petechial hemorrhage. There's a loss of elasticity, which leads to the shortening and narrowing of the vagina. The limited blood flow to the tissues causes decreased vaginal secretions, leading to insufficient lubrication. Because the female urethra, bladder, and the pelvic floor musculature are derived from the same embryonic origin, this is what Dr. Ragini was talking about in the morning, as the distal vagina, and possess many estrogen receptors, these atrophic changes may also lead to symptoms of dysuria, urethral discomfort, pelvic organ prolapse, and stress urinary incontinence. The decreased estrogen is also going to affect the vaginal cytology, which is seen by the vaginal maturation index. This is the ratio of the superficial, the intermediate, and the parabasal cells in the upper third of the vagina. So what happens is that when we take even a pap smear in postmenopausal women, we will usually get that we see a lot of parabasal cells. So basically the parabasal cells increase with the concurrent decrease in the superficial squamous cells. Additionally, a lack of estrogen results in a diminished glycogen content. Now, what happens when the glycogen decreases? This inhibits the lactobacillus growth because the normal lactobacilli need glycogen to eat. It contributes to decreased lactic acid production and increases the vaginal pH. So, menopausal woman's vaginal pH is going to be much higher than a woman who is in her reproductive years. Ultimately, the heightened pH is going to host pathological bacterial colonization, which might give infection and discharge. So this is not a very well-known fact, but like estrogen, the serum androgens and the DHA also markedly decrease with age and the menopausal status. So 60% of androgens present at age 30 are lost by the time the menopause occurs, with the serum DHA also showing a similar decline. So coming to the therapy, the first and the most common and the first thing which comes in our mind is systemic estrogen therapy. This is indicated for vulvovaginal atrophy only in the context of menopausal vasomotor symptoms. If there are no vasomotor symptoms, we do not use the systemic estrogen therapy, because if we are using it in a woman with intact uterus to protect the endometrium, we need to give progesterone alongside. And secondly, only 40% of women using systemic treatment will still have persistent vaginal dryness. So we will need to use local estrogen cream along with the systemic treatment. Coming to the local estrogen therapy, this is the gold standard. It is the treatment of choice. And how does it act? It promotes the revascularization, the thickening of the vaginal epithelium and the lower urinary tract, resulting in increased lubrication, improved elasticity, decreasing the vaginal pH, as well as positive effects on the VMI. It is shown to decrease symptoms of atrophy, including vaginal dryness, irritation, pruritus, dyspareunia, as well as urinary urgency. Since blood flow and lubrication to the vagina increases, it positively affects sexual function too. So, we all talk about, and we teach our patients how to apply the vaginal estrogen, be it estriol, conjugated estrogen creams, or estradiol creams. And we all know that it has to be successively, after a month, tapered down. But it is critical to address care for the vulval vestibule. So this is something that we usually ignore, and that's why I wanted to bring it up. The structures of the external vulva, the vulval vestibule and vagina, derive from different embryonic origins, and they have different blood supplies. So if we are putting a vaginal cream, it is not going to help the woman outside. They respond differently to physical, inflammatory, and hormonal insults. Dyspareunia resulting from vulvovaginal atrophy often occurs primarily at the vulval vestibule. There is problem in the entry itself because of a very hormonally sensitive nature of the tissues. And the vestibule also houses the ostia of the Bartholin skeins and the minor vestibular glands, which play an important role in lubrication as well as arousal. So direct application of local estrogen to the vulval vestibule with the consideration of adding a local androgen as well is important to adequately treat symptoms of vulvovaginal atrophy. And that's why when I started at the outset, I said that even if we are using vaginal creams, we are using them inadequately because we are not talking to our patients about this application. So the present consensus as far as the creams are concerned is that smallest effective dose should be utilized for long-term therapy with eventually tapering the estrogen, whichever one you're using, to maintain its dose once the urogenital function has improved. The principal concern with the use of unopposed estrogen in a woman, like we said, was endometrial hyperplasia. However, these low-dose estrogen formulations, that is the local creams, have been shown not to increase the incidence of proliferative endometrium, and we all know that endometrial surveillance and progestin therapy are not indicated in asymptomatic low-risk women receiving low-dose vaginal estrogens. However, when we say that the vaginal estrogen is not strong enough to affect the endometrium, so obviously if the patient has symptoms of endometrial hyperplasia, that is that she has any vaginal bleeding, please don't ignore it and think that, okay, we are using vaginal creams and that's why it's happening. So any case of postmenopausal bleeding will warrant evaluation with an ultrasound examination of the endometrial thickness as well as endometrial sampling. So much so about the creams that we've been using. I'm going to be talking about certain other things that we have or are coming up. They're used worldwide, and we're hoping that by the time we have the next conference, they're already here in the market. So probably we are well armed with the information. So role of SERMs. Ospemifene, this is a triphenylene SERM, was initially developed, like with raloxifene, as a treatment of postmenopausal osteoporosis. But it was found to have favorable estrogenic effects on the vaginal epithelium. This therapy completed phase 3 trials, focused on the treatment of postmenopausal vulvovaginal atrophy, and should be available with us soon. Just to tell you that the dose is 60 milligrams once daily with food. Coming to T6. T6 are tissue-selective estrogen complexes, pairing a SERM with an estrogen with the goal of relieving hot flushes, treating vulvovaginal atrophy, as well as preventing bone loss, while also protecting the endometrium as well as the breast. The primary objective of the SMART-3 trial was to compare the safety and efficacy of multiple doses of basidoxifene and conjugated estrogen and placebo for treatment of moderate and severe vulvovaginal atrophy. And it was seen that within 12 months, this therapy significantly increased vaginal maturation and improved vaginal dryness. There was a significant improvement in the vaginal pH also, as well as the symptoms. So we are looking at this combination also coming here to us soon. What is the role of testosterone? Testosterone Exogenous testosterone administration improves desire, libido, and arousal as well. And androgenic receptors and aromatase have been identified in the vaginal epithelium also, suggesting both direct and indirect effects of testosterone on vaginal tissue. So it's been seen that the vaginal atrophy symptoms also improved, like dryness and dyspareunia, within a month. And this improvement continued to persist even after treatment was stopped. In some groups, we saw that the vaginal pH also came back to, from 5.5 to 5, and there was a statistically significant 20% increase of the VMI. Role of DHA. Like I said, the DHA goes down as we go into menopause. That is a sex steroid precursor. It's been shown to have positive effects on sexual function. However, like estrogen, DHA declines with age. Oral DHA is not going to help. That's documented already. But there is an advantage of intravaginal DHA on the sexual function, which is still emerging. It's been shown to improve VMI scores and to decrease vaginal pH in 7 days without significantly elevating circulating levels of estrogen. So there's no systemic effect. The beauty of DHEA, that's why probably we need to understand that probably it's something which we should be looking forward to more coming in our country, is that it has been found to act on all the 3 layers of the vagina, including mucification of the epithelium, working on increasing the density of the collagen, as well as stimulating the muscle layer. So, intravaginal DHA may probably be superior to the intravaginal estrogen which we've been using, which mainly acts on the superficial epithelial layer. Role of oxytocin. So we all know what oxytocin is, but it has been shown to increase rates of wound healing, mucosal blood flows, and secretion of several growth factors. So it has been seen that using even a gel of oxytocin for about 7 days, there was a significant improvement upon colposcopic examination with 70% of the treatment group, demonstrating no signs of vaginal atrophy, and 5 of abnormal biopsies at baseline from participants with vulvovaginal atrophy actually reverted to normal after treatment. Role of phytoestrogens. I think all of us have been talking a lot about phytoestrogens. They actually have a role to play as far as local phytoestrogens are concerned. Oral phytoestrogens like having the genistein and diaziin in the soya bean, there's rhubarb, there's black cohosh, red clover, they're not going to help you in vaginal atrophy. But intravaginal application has been seen to show some promise. So isoflavone vaginal gel is effective and the management of vaginal atrophy and may be a viable option in women who have contraindications or they decline hormonal therapy currently, and these are available in our country. Coming to lubricants and moisturizers, vaginal lubricants are designed to reduce friction associated with sexual activity, while moisturizers are utilized as a maintenance therapy to replace normal vaginal secretions. So that's the difference between the lubricants and the moisturizers. So there's a commonly used vaginal moisturizer, which is carbohyl-based vaginal moisturizer, which improves the vaginal moisture and elasticity, thereby reducing symptoms of itching, irritation, and dyspareunia, and also has a positive effect on the VMI. Lubricants may be water, silicone, or oil-based. Remember that the improvement is often temporary. The frequent reapplications are necessary. Lubricants and moisturizers do not reverse urogenital aging, but they compensate for the anatomofunctional consequences by improving sexual comfort and maintaining the vaginal secretions. So even hyaluronic acid has been used, which these vaginal gels allow for hydration and repair of the vagina without irritating the mucosa. These probably have a role to play in women with, especially who are breast cancer survivors, where we are a little skeptical of using any estrogen even today. So the vaginal pH-based gels containing lactic acid are also available, which promote a pH of 4. So like we were discussing that when the pH increases, it's not comfortable for the woman, she's going to have more infections. And these have been studied as non-hormonal alternatives for treatment of vaginal atrophy amongst breast cancer survivors. So what can we use in breast cancer survivors? This is again another topic that comes up all the time. So the American Society of Clinical Oncology says today that lubricants and vaginal moisturizers should be the first line therapy. Systemic hormonal therapy in breast cancer survivors is contraindicated by all international guidelines due to lack of safety data. Currently, the use of vaginal estrogens is usually not recommended due to the possibility of their systemic absorption and consequent increase in hormonal blood levels. So they should be used only in conjunction with the oncologist who is treating the patient. If it is intractable, we could be using small doses for a minimum time. The safety of intravaginal DHA and oral ospemifene after breast cancer has not been established, but it looks promising. Probably in breast cancer survivors, we can definitely think of using lasers. So a lot has been said about lasers earlier, so I'll just be just sharing that in vulvovaginal atrophy, the two which have been seen to have results is the microablative CO2 laser and the non-ablative phytothermal Ebrium YAG laser. By microablative, ablation is destruction and photothermal is heat. So the effectiveness of the ER YAG laser for vaginal atrophy is, it's a non-surgical, non-ablative thermal technique which produces vaginal collagen hyperthermia following the remodeling and synthesis of new collagen fibers without heating up the vaginal lining itself. So it results in enhanced vaginal tissue tightness and elasticity and consequently improved symptoms of vaginal atrophy. The vaginal microablative CO2 laser was introduced in 2014, and how it works is by exploiting the heat generated by the vaporization of the water in the cells in the deeper lamina propria. Energy and consequently microablative impact are precisely delivered in order to limit surrounding tissue damage. The ultimate effect of this hyperregulated injury causes neocollagenegenesis, neovascularization, and consequential improvement in the vaginal pH, moisture, blood flow, and ground substance turgidity. So, women are living longer, healthier lives. The importance of vulvovaginal health and maintenance of intimacy is being highlighted in social media and is finally making its way into the doctor's office. So probably all of us need to be aware of this. The internet has especially provided an open anonymous forum for discussion of formerly taboo topics of women's sexual health, function, and desire. As patients present to clinicians, it is essential to be able to identify vulvovaginal atrophy, differentiate it from vulval dermatosis, and provide acceptable treatment options based on the patient's risk profile. In short, vaginal estrogens have been the staple treatment for vulvovaginal atrophy for many years. Research shows increasingly reassuring evidence for safety of local estrogen application. Over time, studies have shown a trend towards lower doses of local estrogens. SERMs, with or without estrogen, that is T-sex or SERMs, are an exciting area of research for treatment for vulvovaginal atrophy and other menopausal symptoms. Osfina's recent FDA approval for treatment of moderate to severe dyspareunia demonstrates progress in awareness and treatment of overlooked and ignoring symptoms of menopause. Similarly, T-sex, which strive to address multiple menopausal problems like hot flashes, vulvovaginal atrophy, and bone loss, while still protecting the uterus and breast, serve as hopeful options of the future. Thank you.